Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. I welcome everyone to the second edition of our Hep Test webinar series, where we'll be looking at different options for scaling up hepatitis C testing. Hepatitis C testing is a critical success factor in our progress toward hepatitis C elimination. By some estimations, only about 1 in 5 people living with hepatitis C infection are aware of their status. And through modeling conducted by WHO, over 6 billion people will need to be tested so that we can find all of those people currently living with this undiagnosed infection so they can be linked to life-saving care. Now, there are different options for scaling up testing through using a combination of laboratory-based antibody and virologic detection assays, or by using a combination of point-of-care and lab-based assays, or having all of that testing done at the point of care. And our objective today is looking at those different options and how they have been operationalized to scale up to test large numbers of people in countries around the world. We'll be having a series of presentations. Please use the chat feature to make comments as we move along for others to hear your points of view, or to see your points of view, and to use the Q&A function to pose questions to the presenters that we will do our best to get to during our presentations. So today we'll be hearing from presentations from Rwanda, Mexico, Egypt, Vietnam, and the country of Georgia. So let's get started. I'm pleased to introduce Dr. Janvier Saramundo, who is the Director of the Sexually Transmitted Infections and Other Bloodborne Infections Unit in the Rwandan Biomedical Center, which is where the viral hepatitis program is located and is under his responsibility. His other accomplishments and positions are outlined there. He will be joined by Dr. John Makusa Damascene, who has many years of clinical experience in taking care of people with viral hepatitis in Rwanda and conducting a variety of clinical research projects, and has been very extensively involved in the hepatitis C elimination program in the country of Rwanda. So let's hear from both of these physicians, and then we will move forward in our program. Thank you.
Good morning, good afternoon. Allow me to present on the scale-up of HCV testing to reach elimination goals in Rwanda. I'm Dr. Janvier Saramundo, the Director of Sexually Transmitted Infections and Other Bloodborne Infections in Rwanda Biomedical Center. And I will be with
Dr. Makusa Damascene. I'm working with Dr. Janvier in Rwanda Biomedical Center.
HCV continues to be a global public health threat worldwide, but also in Rwanda. In 2017, we conducted a mass screening campaign for the general population, prisoners, and patients living with HIV. We observed that the group of people aged 55 years and above had higher HCV antibodies prevalence. Among the general population group, we had the prevalence of 16.46%. Among the prisoners, we had a prevalence of 12.63%. Among the patients living with HIV, we had 10.64%. And the overall average prevalence was 4%. Allow me to take through the history of HCV management in Rwanda. It kicked off with the hepatitis unit creation, as well as the creation of the technical working group in 2011. From 2011 to 2014, HCV guidelines were developed, and the testing was initiated in few sites. In 2015, the national policy was adopted, and the first patient was treated using sofosbuvir and ribavirin. In 2016 and 2017, we started to screen high-risk groups, including patients living with HIV, prisoners, and people aged 45 years and above. We were using ELISA machines in 13 sites, and the treatment was in place, which was happening. In 2018 and up to 2020, we are conducting an HCV elimination implementation. It was launched in 2018, December, and the plan was for 5 years, starting by 2019 up to 2024. The initial screening targets were 4 million people aged 15 years and above. And as we have now achieved the initial target, we are aiming to screen more people and reach a target of 7 million people, which is the total of people aged 15 years and above across the country. Mass screening campaigns have been a key strategy to conduct an aggressive case finding in Rwanda. This has been implemented in 3 different phases. From 2017 up to 2018, the mass screening campaigns were about to screen high-risk groups, as said. And in 2018, 2019, they were focused on the general population. And from 2020, we are no longer conducting mass screening campaigns, but we have decentralized all the services to the health centers, which are the lower level health facilities, so that people come to the nearest health facility for a routine care and treatment. Among our high-risk groups, we include HCV, HIV, HCV co-infected people, the people aged 45 years and above, the prisoners, healthcare workers, female sex workers, MSM, as well as people that were born before 1985. Our screening and treatment algorithm starts by HCV antibody test, which is a rapid test, and we are no longer using ELISA test, which is which has a long turnaround time compared to the rapid test. When the person becomes negative, there is no further action, it's fine. When the person becomes positive, we need to perform a second test, which is a confirmatory test. Those tests can be HCV RNA, which is currently used in country, but also we can use HCV co-antigen, maybe in the future. When the target is detected, it means that that person needs treatment, and we treat all. We don't have any eligibility criteria. We treat for 12 weeks or 24 weeks, depending on the severity of the disease. The antibody testing that is used is ST-Bioline rapid diagnostic test and used across all health facilities in country. The turnaround time is around 20 minutes maximum. The PCR testing is a confirmatory test, as said, and the PCR samples are venous whole blood samples collected directly after having a positive rapid test. They are shipped to 15 PCR testing hubs for analysis, and we use Roche and Abbott platforms for almost the same price. The real-time quantitative PCR is used with a batch of 24 samples each. The turnaround time is around 1 up to 2 weeks, and the patients are informed of their results via electronic system, but also hard copies are transported by cars to sites. there is an ongoing integration of SMS and emails in the HIS2 for M&E. And there is a general integration of care, either at the level of the program, but also at the level of the health facilities. So hepatitis, STIs, and HIV care is integrated. So we have trained human resources managing hepatitis across all levels. Going through the HCV cascade of care, out of our 12 million people Rwanda population, we have a target population to be screened of 7,157,116 people aged 15 years and above. That's the total of the population aged 15 years and above. And out of them, we have been able to screen 4,165,729 people. Of them, HCV, 84,000 people and 7 had positive antibodies. 41,620 had HCV viral load detectable. And we have initiated on treatment 38,980. Allow me to give the floor to my colleague, Dr. Makuza Jean Damascene, to present the next slides.
Thank you very much, Dr. Janvier, for the floor. Let me start by the pyramid of health system in Rwanda, which started with community health workers up to referral hospital. And then at the community health workers, we can do community sensitizations. Then for health posts and health centers, counseling and screening can be done there. And also sampling for sample which will be used for confirmation, and also for control of TUA. You can see that we have health center where treatment is being done now currently. Before, I mean in 2016, from 2016 up to 2018, HCV services were conducted in the hospital, in the hospital, provincial hospital, then district hospital. Now, at every health facility, meaning health center and or hospital, screenings being done there. Coming to hepatitis test, treat, and cure, the cost per person is about $100 US, which include the screening test, viral test, treatment cost, final viral test, and the clinical cost. As Dr. Janvier said, the treatment and the testing is being given to the population free of charge during this time of HCV elimination phase. And only the patient pay for consultation and biological exams. And we are still negotiating with health insurance in order to cover also those tests and those tests and treatment after elimination. Coming to funding, as you know, hepatitis does not have a sponsor. We are using Global Fund, HIV Fund, that are saving from other activities. We are also doing that reduced budgets to negotiated and reduced prices. Coming to this distribution of hepatitis antibody before HCV elimination currently, you can see that before in 2017 we had a general prevalence of hepatitis antibody to 4%, and now we can see that currently it is 1.8%. The difference resides in that the target population was different. For 2017, people over 25 old were concerned, while now or currently people over 15 years are concerned. One fight toward hepatitis elimination, we have key achievement HCV management. These include approved national guideline in place, rapid tests and viral load testing in place, ongoing HCV elimination, which include more than 1,200 healthcare providers trained on HCV management, which include the doctors and nurses who are treating HCV. We have services which were decentralized at health centers as seen before. We have started, and now we have 4 million people have been screened to date, and we have people over 40 people who either have been treated or are on treatment. We have current prevalence of HCV for people over 15 years, around 1.8%, from 4% in 2017. Key enablers for this achievement, we have high-level leadership support. We have the centralization of services and task shifting. We have result-based planning. We have financing, which include price reduction negotiation, domestic and external funding. And we have partnership between the government of Rwanda and other institutions, international and national. As the challenges we have, one challenge is funding. As I said before, we do not have a sponsor, but you can see that there is insufficient budget from usual fund. As you know, as I said before, we use the saving from HIV activities. Another challenge is the cost of testing and treatment, which is still high. Even it has been reduced, it is still high comparatively to other diseases. The challenge is the reluctance of health sanctuaries to ensure treatment, as it is still expensive. The challenge is the monitoring and evaluation, which is still complicated because of the tools which can be used, also expensive. We have a slowdown of HCV screening, testing, and treatment activity due to COVID-19 safety measures. The overall HCV viral testing platform used also for COVID-19 testing, in addition to HIV as before. For next step for HCV testing scale up, we are going to continue expansion of testing using rapid test for universal coverage. We are going to introduce HCV self-testing to optimize the access to HCV testing. We will expand viral testing from 15 sites to all hospitals or health centers, either using the existing gene expert, which are dispatched in almost all health centers, and also we can use point of care machines. We are going to continue negotiation for testing and treatment price reduction. We also continue to negotiate with health insurance for a full coverage of hepatitis testing and testing services. We wish also to strengthen monitoring and evaluation program using an electronic system for hepatitis data management. Finally, we want to achieve HCV elimination, and we hope we will achieve this target. Thank you very much for your kind attention.
Thank you very much for that excellent overview of the status of the program in Rwanda. We did receive questions in the Q&A box during that presentation, which the presenters are already responding to. So we will move on to our second presentation from Mexico from Dr. David Kurasinovich, who is the Director General of the National Institute of Medical Sciences and Nutrition. David's held a number of leadership positions in Mexico, including being president of the National Academy of Medicine there. He's heavily published on the complications of end-stage liver disease, particularly liver cirrhosis, and has really sparked the development of a hepatitis C elimination program for the country. So let's hear from David about the status of scaling up hepatitis C testing and linkage to care in Mexico.
Good morning. I want to express my appreciation to the Coalition for Global Hepatitis Elimination and to the Task Force for Global Health to invite me to this webinar on hepatitis C. I will be talking about scaling up HCV testing for elimination in Mexico. I would like to start by mentioning how was the situation before 2018, up to 2018. You can see in this slide that when we screened blood bank samples, we screened almost 2,720,000 people, of which were accepted for evaluation approximately 1,800,000, and the prevalence of antibodies to HCV was 0.5%. I took one of these studies in the general population, and as you can see in this slide, which included 71,322 individuals in the general population, the prevalence of anti-HCV antibodies was 0.5%, and when we studied their viral load, that decreased to 0.3%. So the previous situation in Mexico is that we estimated a viremic prevalence in the population of 0.4%, with an estimated number of infected persons of approximately 550,000 people. Up to 2018, we were able only to treat approximately 6,000 people in all the years previous to 2019, and I will show you later on how this compares to the data we have at present time. We decided that we needed to facilitate the diagnosis, and we need to increase the awareness, which is essential for screening and early detection, and also to allow the identification of patients at risk. And this is very important when we consider the possibility of installing an elimination program throughout the country. We also then decided how to facilitate the diagnosis, and we decided to use point-of-care testing, because this gives us easy access to rapid diagnostic at the point of care, and it also allows, obviously, the testing and the results to be obtained in the same visit. Therefore, patients do not have to be coming back to do their testing. I will show you later on that at the same time that we do the point-of-care testing, we take a sample for the possibility of having to check the viral load. The other advantage of the point-of-care testing is it can be done outside the clinical laboratory, and it can also be interpreted by non-specialists. And this point of non-specialist is very important, because when we designed the National Plan for Elimination of Hepatitis C, which we began to do in 2019 and implemented in 2020, our aim was to identify and treat approximately 20,000 patients with hepatitis C in 2020 and increase it to 40,000 yearly for the next 10 years. So at the beginning in this year, in 2020, we tried to identify the patients with viremic hepatitis C in particular settings. For example, our goal is to eliminate hepatitis C in this year in co-infected patients with HIV, and to facilitate the access to treatment for those patients that are being detected in the blood banks. And for that, it's very important to have the help of the primary care physicians, because Mexico is a huge country and it's very heterogeneous, and we need the help of the primary care physician for screening and also for treatment. You can see here that we have approximately 300,000 primary care physicians in the country that could help to this purpose. So our aim was also to train the primary care physician and to have a consistent supervision of them, having a linkage between the different health systems in the country. And I think this is very important to consider not only the screening, but also who is responsible for doing the screening and who is responsible to implement the treatment, which I will be showing you later on. We then negotiated a combo with the government and the industry, which includes point-of-care testing, the viremic confirmation with the viral load, ALT, platelet count, creatinine, and antigen of hepatitis B. And we also have the help of 125 specialized nurses that go to specific sites, for example, when we screen prisoners or if we're doing in addict clinics, etc. And we have an education program for general physician. And most importantly, we designed a national registry, which I will be showing to you in a few moments. I would like to say that this combo is free of cost for every individual in Mexico. So this is a program with equity, so everyone can access without the cost to the testing and to the treatment. And I would like to spend a few moments to tell you about the platform that we designed. And we built a Mexican observatory with the aim of being able to have the hepatitis C elimination program by 2030. Let me go through the platform, which you can see in the left side of this slide. Once a patient comes in for screening, we advise him of the program, we obtain verbal authorization for possible testing, and once the patient accepts, we proceed with the screening. If the screening is negative with the point-of-care testing, then the process is finished. If by doing the point-of-care testing, which we get the results in a few moments, then the patient signs an informed consent, so we can put his data, his demographic data of identification and contact into the platform. Once we put this into the platform, and this is very important because the patient will be followed up through the whole process of treatment. Then we investigate risk behaviors. I put an example here of pregnancy, transplant, HIV, and all the other risk behaviors that we know. And we request for the patients to have an appointment in the institution of care in 2 weeks. The reason why we decided in 2 weeks is because approximately for obtaining the results of the test, it takes 7 days through the whole country to get the result. So we want to make sure that we don't have any problem and the appointment is given to the patient in 2 weeks. But the important thing is the appointment is given in the moment that we register the patient. Before we have the result of the viral load, he already has an appointment with the physician. We then generate a label for future sampling. So we are going to be able to follow up not only the results of the testing at the entrance to the study, but also 3 months later and 3 months later to get the sustained viral response. If the patient has liver cirrhosis, he is then referred to a specialized unit, and if not, he is being followed by his primary care physician, and we get the automatic registration of the data in the platform until the patient gets negative for the viral load. If he has hepatitis B, he's also being treated, and we follow up the patient in the platform with the registration of the viral load. So through this process, we are able to have a registry of all eligible patients for treatment. We have the possibility of having a data mining tool, which will have the screening criteria of the numbers of dropouts during testing, the compliance, the outcome. And this gives us information for key policies and decision teams in the future, because we have to realize that one thing is to start the process, another the policies that will come in the follow-up of these patients. It also allows us to have the evaluation of the treatment effectiveness of the process, and also it allows us to identify barriers and facilitation processes to engage the general practitioners with the direct antiviral agents. We have a referral system in place for the national healthcare services. So if the patient migrates from the place where he was attended, he will still be able to follow up his treatment. And with all of these, we want to foster the publication of consistent data, which will surely help us to follow up and monitor with the aim that we have to eliminate hepatitis C by 2030 in the country. So let me show you some of the results up to now. This is the slide which I showed you up to 2018, which included several years, and in which treatment was initiated only in approximately 6,000 patients. I do not have the full data until the end of the year, but I can show you some of the data of the federal health system, which takes care of 50% of the attended population. The other 50% is covered by the social security systems of the country. And you can see here that in this year, we have approximately done 138,000 point of care testing. We have obtained positive results of viral load in approximately 5.89% of them. And we have initiated treatment in approximately 8,143 patients. We will have the result at the end of the year of the whole system. But as you can see, in 1 year, we were able to treat more patients than those that were treated up to 2018. And also, we have this year the problem of the pandemic, but hopefully we will have getting close to the 20,000 patients. But we hope that next year we will be able to identify the 40,000 patients that is the purpose of our study. So in my final slide, I would like to mention that some of the lessons that we have learned is the importance of the screening and early detection of patients, because this will facilitate the road to the hepatitis C elimination by 2030. The model of care was transformed, it was simplified, and we have integrated the model with the participation of the different stakeholders. I would also like to leave as a message that it is necessary to migrate, not only from a treatment strategy to go to an elimination strategy in which the screening, the sampling of the patients is very important to detect them before they go on to develop the complications of chronic liver disease. I appreciate very much your attention. Thank you very much.
Thank you very much, David, for that excellent overview of the Mexico program. It would be good to be able to ask David a question as he has to leave for an important meeting with the Ministry of Health. Let me see if that's technically possible for David to come on. Just wanted to ask you a question, David, as regarding the testing policy in Mexico. Is there as we heard in Rwanda, there's targeting certain populations by age or by a setting or by a risk factor. What are the testing recommendations for hepatitis C in Mexico?
Well, this year we decided to target specific populations. We still have the general population plan and it's done, but we have gone strongly to identify the people with HIV, to detect the hepatitis C in them in order to eliminate hepatitis C in them. We also set a program in the addict clinics because that's an important risk factor in Mexico. And this has been accompanied by harm reduction measures. That is, we provide needles to them. We also provide treatment for them. So we have gone specifically to microelimination of the disease in specific groups such as the HIV and the addicts. We also started the program in the prisons in particularly. So at the same time, we have a national campaign of hepatitis C awareness, which is being held in the television and in the radio, asking the people to go to the general hospitals or the primary health clinics in order to get tested. And this will be our next group, which will be focusing next year.
Very good. Thank you very much. Hope you'll be able to return after your meeting where you can be part of the discussion at the end of the program. Thanks again.
Thank you. Thank you.
Thank you. Let's move on to learning more about the Egyptian program. Happy to have Dr. Mohammed Hassani participating. He is he's a hepatologist and gastroenterologist at the National Hepatology and Tropical Medicine Research Institute in Cairo. He's also executive director of the National Committee for the Control of Viral Hepatitis that is responsible for the hepatitis C elimination program in the country. Let's hear from Dr. Hassani.
Thank you very much for inviting me to such an important event to highlight the Egyptian National Hepatitis Response and the HCV Care Program. This is my disclosure. For many years, Egypt topped the list of the countries with the highest prevalence of hepatitis C based on the data came from the demographic health survey in 2008. The HCV prevalence was 15% regarding to the antibody level, while those who were viremic reached to 10% among the age group from 15 to 59. In 2015, the following DHS showed a decline in HCV antibody prevalence reached to 10% and also declining of the viremic patients to the level of 7% among the same age group. This decline was attributed to the deployed infection control programs and the exit of the highly affected group being more than 60 years old in the second DHS. Due to the high prevalence of hepatitis C, it was expected that the long-term complications of liver cirrhosis would affect a broad sector of infected people and reflected on the incidence of cancer in Egypt, which was topped up by the primary liver cancer being the highest incidence in males and in both sexes among different age groups. And it came in the second level after breast cancer in females based on the data of the Globocan in 2018, quoted from the National Cancer Registry. And sure, the final story was the reflection on the mortality trends, showed the steady levels in HCC-related mortalities till the first half of 2020, and we hope that the service reduction under the pressure of COVID-19 will not lead to a surge of HCC-related mortalities, especially in 2021. On the other hand, due to many years of efforts in fighting hepatitis C in Egypt, we started to touch the low difficult hanging fruits, the reduction in liver-related mortalities, which is an essential indicator for hepatitis elimination as per the WHO definitions. The national hepatitis response in Egypt had an exceptionally long history, many challenges and moments of victory. The high HCV prevalence in Egypt was attributed to the massive campaign of anti-schistosoma treatment with a parenteral therapy called the tartar emetics, which was widely used without sufficient needle sterilization and led to massive spread of hepatitis C. Egypt was one of the leading countries in Africa in the Middle East that adopted the introduction of HPV third dose vaccination within the context of the compulsory vaccination since 1992, and since that time the vaccination coverage is maintained to be above 90%. In 1993, the first ministerial decree was issued to make the screening of HPV, HCV, HIV, and syphilis mandatory for all the blood and blood products bags. This was followed in 2003 by the publication of the first National Infection Control Strategy. Then, at a tough and challenging time, a very important decree for the establishment of the National Committee for Control of Viral Hepatitis to be the governing body responsible for drawing of national strategy for prevention, diagnosis, and the treatment of hepatitis C. The first equivalent of the committee was the introduction of pegylated interferon and ribavirin therapy for HCV treatment, which was the only available treatment at that time with a reduced cost enabled to treat nearly 350 chronic HCV patients with sustained virological response reached to 40 to 50%. Also through a network of geographically distributed viral hepatitis treatment center, that program is established and becomes effective on the ground. These viral hepatitis treatment centers are well equipped with diagnostic facilities and have a well-trained staff. The major breakthrough happened in 2014 with the introduction of the brands of the direct-acting antiviral drugs with only 1% of its global price. This group of drugs allowed for treatment of many easy and difficult cases with shorter duration and minimal side effects compared to big interferon ribavirin therapy. This was associated with the kickoff of the national network for the treatment centers and the initiation of the web-based registration system, which allowed for electronic reservation of appointments at the nearest viral hepatitis treatment center for the evaluation and treatment. Not only this, but also the unified platform for data entry for all the patient journey. The second major shift happened in 2016 with the introduction of the generics of the direct-acting antiviral drugs, which are locally manufactured in Egypt and provides us more deployment of HCV drugs and allowed for treatment of nearly 2 million HCV patients. Concomitant to this, an important step was done, which is the introduction of HPV first dose vaccine to enhance the prevention of the mother-to-child transmission of hepatitis B. In 2017, it seems that we treat all those who knew their status of infection, and the number of patients at the viral hepatitis treatment centers started to decline, and many trials for limited and targeted screening were done to discover any patients. Yet we knew well that we still had the bottom of the iceberg containing from 2 to 3 million hidden cases of hepatitis C that need to be discovered. For that reason, Egypt started in October 2018 the most extensive nationwide screening campaign for the elimination of hepatitis B and early detection of non-communicable diseases, which was performed in a time period of 7 months through 3 phases. Each phase included a group of urban, rural, and border governorates. The total number of screening sites is nearly 7,500 sites. The screening was mainly done at the primary healthcare units, which has a perfect geographical distribution. It accounts for 77% of the healthcare system facilities shared in the campaign. Added to the primary healthcare unit, and extra support was done through different secondary and tertiary hospitals, mobile clinics, and mobile teams to enhance the outreach programs, primarily in the border governorates. Besides the sharing also of non-health facilities like youth centers. We had nearly 20,000 teams. Each team consists of 1 medical staff and 1 nursing staff and 1 data entry staff, with a total number of healthcare workers reached to nearly 60,000 healthcare workers shared in the campaign activities. Regarding the training, we adopted the model of the training of the trainers through training of 5,000 healthcare workers on the ideal methods of HCV testing using the rapid diagnostic tests. Every one of the core trainers was responsible for the subsequent training of 10 corresponding persons to do the same job. The campaign was performed over 7 months with an average daily screening reached to 240,000 people underwent HCV testing per day. The test results appeared from 5 to 10 minutes, from 5 to 20 minutes, and those who were tested positive, their confirmatory PCR samples were done in 77 PCR testing hubs with an average daily capacity ratio to 36,000 tests per day. If we have an in-depth look for the screening journey, which was pushed by a huge media campaign, included all types of media tools like TV, radio, billboards, social media, and celebrity promotions. Any person could go to the nearby primary healthcare unit or any nearby hospital to be tested. And we had a 24/7 call center and a hotline that had a great human capacity, allowed for communication with people to notify them with the nearest point of testing based on their residence. After going to the testing point, the person should present his or her national ID, which is a unique identifier to be recorded. And if they previously received the treatment within the public sector, the system generates a message that this person is not eligible or allowed to be tested again. After that, the test was done and the results were double recorded on the electronic data system and also in a pre-designed card. If the person tested positive for HCV antibodies, the system generates a message including the name and the address of the nearby viral hepatitis treatment center for further evaluation and the treatment of those who are eligible. At the viral hepatitis treatment center, which are more than 200 centers, verification of data was done firstly, and the withdrawal of the blood sample for assessment of HCV RNA and other liver function tests, plus abdominal ultrasonographic examination was done. The PCR samples were collected and transferred through a specialized courier to the PCR testing hubs without further movement of those who are tested. These PCR testing hubs were installed in respect to the geographical distribution and also the expected samples to be received. When the test results appeared, it was automatically sent on the lab information system, which could be viewed directly at the viral hepatitis treatment center. And if the patient is treatment eligible, then he receives the direct acting antiviral drugs for 3 months. And after finishing the treatment by 3 months, the SVR test was done through the same mechanism. And also periodic phone calls were done to recover the patient with missed visits. Those who achieved the SVR were issued a cure certificate as one of the promotional actions to push the patients to come back for SVR testing. Now it's my pleasure to introduce you one of our heroes in this campaign. He's one of the data entry personnel, and he have a congenital absence of both his upper limbs and by the toes of his feet. He could do full data entry for more than 1,000 persons shared in the campaign. I think this spirit and ambition was the leading cause for the success of the campaign.
احتجت اعمل اي حاجه ارد على التليفون مثلا برجلي، احط السماعه في ودني، كل حاجه بعملها برجلي اليمين اللي انا بقول عليها اصلا ايدي اليمين مش رجلي اليمين.
There was a great integration between the simple data system at the screening sites, which had a great integration with the national network of the treatment centers and also the lab information system, in which we could easily track the patient journey from the screening site until the final cure. The screening campaign was funded through the World Bank, and by the way, I am always saying that we received the first US dollar 2 weeks after we finished the screening campaign, and all what we paid was through the mobilization of the domestic funds. At a specific time before the campaign, we had to choose between 2 pathways for testing with no considerable difference regarding the costs, either to go for a simple method for screening, which gives you a privilege of rapid movement and service deployment, can be easily done by any healthcare worker, or to go for lab-based usual methods, which could hardly done on this large scale with expected huge amounts of blood samples transfer and processing and limited capacity for outreach. Finally, we prefer to go for the easiest and simple method to do the rapid diagnostic test technology, which allowed us to win this battle. Among nearly 2.2 who were tested positive for HCV antibodies, 1.6 million patients were transferred for the PCR testing at the viral hepatitis treatment centers, and the rest of people preferred to go for the private sector to be managed. 72% of those who are tested positive for antibodies were viremic by PCR, and 92% were eligible for treatment and received a combination of sofosbuvir and daclatasvir plus or minus ribavirin for 3 months, with an overall sustained virological response reaching to 98%. Under the pressure of COVID-19, all the healthcare facilities in all the affected countries worldwide suffered from the transformation of their health capacities to serve the pandemic facing. In Egypt, to try to maintain the healthcare capacities and avoiding the collapse in health services by the gradual utilization of hospitals and manipulating the operation of other non-health facilities like hotels and dorms to evacuate the mild cases. Meanwhile, the utilization of fever and chest hospitals as triaging points and testing points responsible for clinical evaluation and assessment of those who have symptoms. That particular step affects the national hepatitis response and its related services like HCV surveillance system, because most of the viral hepatitis treatment centers and all its diagnostic and treatment capacities are lying inside the fever hospitals, which are used to face the COVID-19 pandemic. And if we look to this representative graph showing a nearly 60% reduction of the governmental funding decrease for all health services related to chronic diseases and surgical interventions due to the reduction of service accessibility and service demands, this stimulus arouses the governmental response to re-push this service offering and the community mobilization to receive it again. And for example, if we compare the period from December 2019 to March 2020 versus the period from May to August 2020 regarding the stability and the progress of HCV screening program, we could find a significant reduction exceeding 70% in the total and the monthly visits, and also the monthly performed ultrasound examination for early detection of HCC under the pressure of COVID-19. And now utilizes those installed systems to improve the testing capacity of hepatitis B, HIV, and also COVID-19. And now with the utilization of this big data, we could exclude anyone tested positive either for HCV or HIV or HBV at any time from the blood donation to save time and efforts for further screening. I will finish with this slide summarizing an updated situation of the WHO definition defined elimination pillars in Egypt, showing an optimum coverage of HPV third dose vaccine and first dose, also screening of 100% of donated blood bags, mandating the use of auto-disabled and auto-destructive needles in all healthcare settings, a significant move in the harm reduction file through the legalization of the opioid substitution therapy program, and the strengthening of the needle syringe program, achieving a great success in diagnosis and treatment of hepatitis C, reaching to more than 90% incidence reduction, and also about 20% reduction in viral hepatitis-related mortalities, and we expect more in the next coming years. No words will be sufficient to thank my colleagues in the National Committee for Control of Viral Hepatitis, the Ministry of Health and Population in Egypt, WHO, country, regional, and HQ, and our colleagues in the World Bank, and the legendary team of the Hepatitis Elimination Program, and the true heroes, the healthcare workers shared in the campaign, and the teams of the Viral Hepatitis Treatment Center. And thank you very much for your attention.
Thank you, Dr. Hassani. Excellent overview of a truly remarkable program that's achieved great accomplishments and improved public health for the country of Egypt, and is really a role model for many countries around the world, as we've seen. Please continue to post your questions in the Q&A function. We have one for Dr. Hassani that he'll be responding to, and then we'll have a short time for discussion at the very end. Let's move on to learn about HCV testing in Vietnam from Dr. Don Dao, who is an assistant professor of medicine in the Division of Gastroenterology and Hepatology in the Department of Medicine at Johns Hopkins University. He's also founded the Vietnam Viral Hepatitis Alliance and directs the Johns Hopkins Center of Excellence for Liver Disease in Vietnam. and his programs are really dedicated to achieving hepatitis elimination in Vietnam. So let's hear from Dr. Dow.
We are pleased and appreciative to participate in this important event. My name is Don Dow. I will share our experiences working in hepatitis C surveillance, screening, and linkage to care in Ho Chi Minh City, Vietnam. Our initiatives also involve hepatitis B. However, for this presentation, I only focus on hepatitis C. The disease burdens of hepatitis C in Vietnam is considerable. In 2017, based on modeling data performed by Vietnam's Ministry of Health and WHO Vietnam, there are approximately 1 million chronic hep C carriers in Vietnam. That is about 1.1% of the population. However, in the high-risk groups, hepatitis C can afflict up to 39% of those populations. Of the total hep C cases in Vietnam, a negligible number has been diagnosed and thus treated. In response to the significant disease burdens of viral hepatitis, in 2015, Vietnam's Ministry of Health released its first national plan for prevention and control of viral hepatitis for the period 2015 to 2019. This national action plan is particularly important in the country because of its political system and decision-making process. The release of the national action plan indicated that viral hepatitis at the national level has been recognized as an urgent and significant public health problem, so all the lower governmental levels can now address the disease burdens. Vietnam is a developing country in Southeast Asia, as shown in red on the map. Following the National Action Plan, we decided to help address the huge disease burden of viral hepatitis there. Strategically, we began by creating a comprehensive multi-year community participatory and research-based program to generate reliable baseline data. And through this baseline evidence-based data as groundwork, we then build a coalition of key stakeholders who will then engage, advocate, and influence policy changes among stakeholders, including Vietnam's Ministry of Health. So we selected Ho Chi Minh City to demonstrate this evidence-based advocacy strategy in influencing policy changes. Ho Chi Minh City is located in southern Vietnam, as illustrated here. It has a population of 12 million. It is a prototype for Vietnam. This slide also shows an overview of the study designs involving 3 different phases, 1, 2, and 3, in a stepwise fashion with a corresponding sample sizes from small to large. We deploy a public health method, probability proportional to sample size, or PBS, to representatively sample 20,000 adults 18 or older out of 12 million residents in Ho Chi Minh City for this study. Major stakeholders and overall collaborations are comprised of government and public health sectors, NGO, and private entities. And this is a model of private and public partnership. We also wanted to demonstrate it through this study. Ho Chi Minh City Department of Health serves as an umbrella, providing an overarching legal and cultural support. With the Vietnam Viral Hepatitis Alliance, an NGO is responsible for funding, study design, etc. Pham Nhat University of Medicine, a local university is responsible for outreach activities as well as ILB approvals. Medical Center, a private sector, is responsible for lab testing and provision of linkage to care. The program design is following. For the pre-screening and screening phases, as mentioned, we deploy PBS to select 100 wards out of 322 wards in Ho Chi Minh City. Under each ward, we then selected a certain number of commutes. Under each commute, we chose a certain number of neighborhoods, and under each neighborhood, we invited 100 adults or 2 adults per household for a total of 50 households. And again, this is a PBS design for a representative sampling of a population. After we go through all of these selections, our outreach teams go to each household up to 3 times to invite for participants. Of the invited individuals, if they agree, they will come to a local clinic where they are given educational booklet, sign the consent, answer KFB questionnaire, get their blood drawn, and after they did all of this, they receive incentives and wait for the results in 2 to 4 weeks. Failure to participate is also defined as shown on the slide. In the post-screening linkage to care stage, the screening participants return to the same local clinic where they have their blood collected to receive the result envelope and provide signatures to certify that they have received the results. In the result envelope, they are provided the result interpretations and linkage to care referral network informations as shown in these boxes. Our care navigators will then call back to the screening participants at the predetermined time points for follow-up. For those who have not been linked to care, they are given appropriate guidance as next steps. Along the cascade of linkage to care, we again employ care coordinators for navigation. These are some of the pictures showing a local clinic where screening participants come for registration and answering KFB questionnaires and subsequently have their blood collected by mobile phlebotomists. This slide demonstrates an example of how we have been engaging key stakeholders through national conferences for healthcare providers and community education seminars for patients. And here are the results of the screening and linkage to care. The prevalence for anti-hepatitis C antibody positivity is 2.2%. Of those, 70% are Hep C RNA positive. This is translated into 1.54% active Hep C infection prevalence in Ho Chi Minh City. 69% had anti-HBC, and that is antibody to the core total of hepatitis B. 5.6% had HBsAg positivity, and 55.7% had central obesities. These statistics have implications in the clinical management of hepatitis C. 91.6% had low to middle income level. That is, they earned $340 per month or less. In comparison, the cost for a treatment course of hepatitis C with DAA in Vietnam is $1,500. 71% had less than high school education. Regarding linkage to care, 92% reported receipt of program follow-up materials. 91% had insurance and 61% consulted a hepatology clinic. Of those who consulted hepatology clinic, 31% used insurance to pay for Hep C clinical management. Hepatitis C screening and diagnostic costs, point of care or rapid test cost is about $1.30. And this is not widely used in community in Vietnam. Hep C PCR cost is about $50 US. Screening test is currently not covered by the National Health Insurance, and patient would pay for 50% of the treatment cost for Hep C treatment with DEA in Vietnam. So the copay is 50%. Current challenges for Hep C elimination in Vietnam. Here I just highlight some of the major challenges. There are inadequate workforces and advocacy groups dedicated to viral hepatitis elimination efforts there. Because of these screening tests yet to be reimbursed by national insurance, for example, treatment cost is relatively unaffordable by most who need it. Lack of a formal surveillance database for viral hepatitis at multiple levels of healthcare systems in Vietnam. Focus and investment in viral hepatitis have been further interrupted by COVID-19 pandemic. Financing challenges have always been the case. Funding for Hep C testing and treatment scale up is almost non-existent in Vietnam. Lack of incentives to take care of patients with hepatitis C from physician and healthcare systems is also noted. Lack of decentralized care for Hep C in community and underutilization of clinical care coordinators for Hep C screening and access to care. So for us, our next steps for Hep C testing and treatment scale up include, and that is, we have been grateful to be able to participate in HIT study. This study is being led by the Coalition for Global Hepatitis Elimination. The aim is to influence policy change among key stakeholders through hepatitis B and C elimination tool. We also putting together a program entitled Making Hepatitis B, Hepatitis C History in Cà. This program aims to eliminate Hep B and Hep C in Cà Mau province, Vietnam. Cà Mau has a population of 1.3 million, and most of the population there are underprivileged. And this program is being supported by a local philanthropist. And this slide is my acknowledgement slide. And I thank you for your attention.
Thank you very much, Dr. Dow, and for your pioneering work in Vietnam to make progress in Hep C elimination. Let's move to our last speaker from the country of Georgia. We'll be hearing from Dr. Maya Alkahashvili, who's the head of the Lugar Public Health Research Center. Maya has done remarkable work in a variety of laboratory science and clinical medicine, developed the first quality assurance program for hepatitis testing in the country, and has been a key leader in the hepatitis C elimination program for the country of Georgia. So let's hear from Maya at this time, please.
Dear organizers and guests of this webinar, first of all, thank you for putting your name and effort to organize this webinar. And thank you for inviting me to speak on behalf of National HCV Elimination Program of Georgia. Despite the major successes achieved towards the elimination, hepatitis C infection still remains work in progress. But ongoing COVID pandemic actually showed that thanks to the steps undertaken within the implementation of HCV program, the overall national COVID-19 response capacity has increased significantly in general. In my presentation, I'm mostly going to focus on the laboratory diagnostic strategies implemented at different stages of the elimination program and the outcomes of the steps taken towards the improvement of the laboratory diagnosis of the hepatitis C infections throughout Georgia. Please, next slide. Now let me start my presentation with a brief overview of where we started 5 years ago before the implementation of the National HCV Elimination Program. Based on a sero survey conducted in 2015, prevalence of chronic HCV infection was 5.4%. The survey also showed that the main genotype in the country was a genotype 1 and followed by genotype 3 and 2. Next slide. In 2015, with active involvement of the Georgian government, of USA CDC also, the HCV elimination program has been started. The implementation strategy was approved years 2016, 2020, and 20 with the ambitious targets of diagnose 90% of infected individuals, treat 90-50% of diagnosed patients, and cure 90-50% of those treated. The strategy consists of different directions, such as promotion, awareness, advocacy, education, HCV prevention, infection, HCV infected persons, identification infected persons, also lab capacities, HCV care and treatment, and surveillance. Multi-sectoral working groups are involved in improving and strengthening each directions. Next slide, please. In this slide, you see the care cascade. As of September 2020, 70% of adult population has already been screened for HCV at least once. 56% of the target population initiated HCV treatment, and 98% of cases has successful treatment outcomes. Among 50,000 persons tested after their first round of treatment, 98,000 patients achieved SVR. Next, please. And now we are going to the testing algorithm. In the beginning of the HCV elimination program, different diagnostic methods were introduced through the country. Both rapid and laboratory-based serology methods were chosen to target and universal screening strategy. Ministry of Health designated a lead agency at central level that was responsible of implementation of HCV screening activities. In parallel, a web-based registry was developed to track screening outcomes among all persons tested for HCV infection. In 2015 and 2016, screening for hepatitis C has gradually been offered free of charge through several governmental programs across the country, covering general population, inpatients, outpatients, pregnant women, blood donors, harm reduction centers, military services, and other groups. Next, please. In that slide, you see quantities of screening. During the last screening, last 2 years, screening rate of outpatient clinics in general population reached more than 50% of the total number of screening conducted in all sites, with 1.3% positivity rate. Next slide, please. Next step in laboratory diagnostic is the confirmation of anti-HCV active infection. The diagnostic landscape for hepatitis C infection was introduced by different confirmation methods, and there were difficulties with the quality of tests. Reagent was not verified, and with the procurement of small batches also, it was cost issues. After introducing the HCV core antigen testing, confirmation became centralized and new diagnostic algorithm was approved. The decision was based on HCV core antigen testing, accuracy and feasibility study. The overall agreement between HCV core antigen and RNA test was 97%. Next slide, please. In that slide also you can see HCV testing algorithm that was implemented for the HCV confirmation. And next, please. Confirmation of HCV infection by core antigen using a centralized approach of confirmation. Introduction of core antigen test-based confirmatory testing was a game changer, enabling the program to offer free of charge confirmatory testing all anti-HCV positive individuals. In 2017, Lugar Center, as a reference center for the hepatitis C, started performing core antigen testing and implemented centralized laboratory approach. Now, next slide, please. In that slide, you see HCV core antigen testing from December 2017, October 2020. And around 25,000 samples are received at Lugar Center and tested, and approximately 30% of them were non-reactive. Next slide, please. And according to the algorithm, these all HCV core antigen negative tests were tested on PCR. And approximately 11% of the negative and gray zone samples were HCV RNA positive, but most of them were very low positive and genotype was undetermined. Next slide, please. Despite the well-organized NCDC public health laboratory network and significant coverage of the country and sustainable access to diagnostics through centralized procurement of reagents at a fixed rate reimbursement system, centralization of confirmatory testing had significant disadvantages. Turnaround time of testing was up to weeks and rejection rate of samples were very high. At the same time, some different confirmation methods were implemented in private public sector. And from November to now, 2018, confirmation testing of anti-HCV hospitalized individuals became centralized, allowing shortening the time from screening to diagnosis, active infection, and to treatment referral of patients. Since 2018, have implemented optimal and cost-effectiveness testing strategies as well. The Gene Expert was introduced in the country. There was approximately, we have already more than 60 Gene Expert machines throughout the country, and we implemented the Gene Expert method using plasma and finger stick samples as well. Next, please. In that slide, you can see the variation of the methods, test kits, and equipments introduced in the country. Next slide, please. In this slide also, you can see confirmatory tests conducted by year 2015-2020 October. And you can see that during the last 2 years, confirmatory testing rate using Cepheid platform is increasing. The reason is geographical accessibility and easy performance and very short turnaround time. Next slide, please. Confirmation of HCV active infection. This was also next step of blood transfusion safety in Georgia. Additional progress towards the elimination is also to strengthen a blood safety system and decrease the HCV transmission through the blood donations. In 2020, the blood state safety program, state blood safety program, launched NAT screening, and by supporting Global Fund, we procured the equipment, and 24 blood banks already are participating in the NAT screening. The NAT screening is performing at Lugar Center, and anti-HCV serology methods are introduced in the blood banks. And serology and NAT discordant samples all are testing for NAT discriminatory NAT testing. And also the anti-HCV positive samples are confirmed by using core antigen testing at Lugar Center. Next slide, please. Since 2017, the National External Quality Assessment Program has been implemented in Georgia with the support of CDC Atlanta. The NCDC Lugar Center is producing the national HCV proficiency testing panels for HCV, and the panels are sent out to all the laboratories involved in HCV elimination program 3 times a year. And they all receive data, are analyzed, and giving feedback to the laboratory to ensuring for the effective laboratory monitoring. The annual meeting stakeholders ensures the effective exchange of the existing issues and challenges concerning the HCV laboratory diagnostics, as well as provide the opportunity to introducing of new technologies and laboratory techniques for ensuring the good laboratory practice. Now, next slide, please. We move to the diagnostic costs. A significant number of patients did not have access to PCR testing, as the test was not fully covered by the National Hepatitis C program at this time, where we started the HCV elimination program. And out-of-pocket payment was 30% for vulnerable populations and 70% for general populations. In December 2017, when the core antigen testing was introduced in the country, first confirmatory testing of active HCV became free of charge of patients. Since September 1st, 2018, the genotyping of HCV individuals with active infection has been provided at no cost. But after introducing the pan-genotype treatment, HCV genotype testing is no longer required. And from August 2019, it has become possible for patients to receive diagnostic and treatment services free of charge at all. Next, please. Now about the current challenges related to COVID-19 pandemic. Unfortunately, in this slide, you can see that significant drop in screening numbers since the pandemic has started. Also, enrollment in HCV treatment remained more stable, but still the number is very low. Next slide, please. Now about the COVID-19 challenges in laboratory diagnostic part. They implemented laboratory network for HCV elimination through the last 5 years, played this fundamental role for the development of rapid response against the new coronavirus pandemic. Existing PCR diagnostic capacity allows with the decentralization and the rapid scale up of SARS-CoV-2 infection PCR testing capacity up to 1,250,000 within the 10 months period. And also based on the experience with HCV EQA program, new external quality program for COVID-19 infection was implemented through the laboratory network. And now next steps, please, next slide. Next steps for hepatitis C testing scaling up. A revision of the existing elimination strategy is already planned, and we started working on new elimination strategy for the next years. And new HCV, HPV seroprevalence survey, along with COVID-19 seroprevalence study, is scheduled to be conducted in 2021. And HCV prevalence, genotype distribution, risk factors, and awareness education will be studied to assess the progress toward elimination and copia current situation in 2015. And strengthening the national laboratory system and countrywide national quality insurance programs by establishing the laboratory training hub and the ECHO hepatitis C diagnostic laboratory community. Now, in next slide, acknowledgements to all organizations, including Ministry of Health, CDC, EBO Diagnostic Find, and our National Center for Public Health Disease Control and Public Health, Georgia. And that was all. Thank you for your attention.
Thank you, Maya. Excellent overview of the Georgia program, particularly how it's been very useful to respond to the pandemic of COVID-19 in the country. We're in the discussion period now. We're going to try to have at least one question for every presentation. We're going to start off with some remarks from Dr. Paige Armstrong, who's the Associate Director for Global Health in the Division of Viral Hepatitis at the US CDC. Paige?
Hi, everyone. Hi, John. Thank you very much. Yeah, these were some fantastic presentations. And, you know, I really think you see a lot of different approaches here and a lot of different challenges. You know, I think the coverage certainly of national insurance and national programs around hepatitis C seem to be a real consistent theme across what was possible, what were some challenges, and how those were mitigated. You know, I have a question that I think probably will touch on most of the speakers, but I will direct it at Dr. Ashkavili first, which is, you know, I think linkage to care continues to be one of the biggest challenges. And looking at all of the care cascades across all of the programs, it seems that that's where the numbers drop off most considerably. I saw with the Vietnam example, there was a nice employment of people to try to ensure linkage to care. And I guess I just wondered with the Georgia program, and Dr. Ashkavili, if you could comment a little bit on how the different models of testing and diagnostics have proven beneficial, found that those different models have really been effective in making sure that people can get connected to DAAs and treatment in a more thorough manner. Thank you.
Thank you. Maya, would you like to comment?
Okay. Thank you, Paige. Connection is not so good. Okay. The question is related to the linkage to care. Yes, I understood correctly. Yeah. Okay. First of all, for today, linkage to care, it is not so low relating to the COVID-19. We are first of all, the screening is open for all parties, all citizens of Georgia, and after confirmation, the patients will be referred to the COVID treatment clinics. We have almost I don't remember just number how many treatment clinics we have, but we have this is accessibility for all Georgian citizens for all regions. We included outpatient clinics also, and the hospitals, and all sites are part of the treatment program. So the patients are referring to the clinics where they are confirmed as active infections. And rate for today, it's the same, compare confirmed cases and linkage to care patients. But some, because all treatments are, and all services are free of charge for all patients at all. That is main reasons, and also we have very good awareness campaign in Georgia, and all citizens know about hepatitis C, and all free of charge, stages to get the treatment of HCV active infections. Okay, maybe that's only my comment for that. And also, as for the care cascade, approximately 98% of patients who gave the treatment are already got SVR. It's very high rate of the SVR cases in Georgia.
Thank you. Thank you very much. I think if Dr. Dow is still with us, there were several questions in the Q&A box regarding the cost of PCR and the cost of HCV treatment, which is quite a bit higher than some of the other presentations showed for the other countries. What do you think are some of the reasons for those higher costs in Vietnam, and what do you think are some of the options for reducing those costs?
Thank you, John. I think a major reason for the high drug cost is the lack of competition there. Per our understanding, there's only one provider of medic DAA in Vietnam at this point, so there's lack of competition. And the cost I provided includes lab testings, diagnostic tests, fibroscan, hepatology consultation, and the DAA. So the total at this point is about $1,500.
Right. It'd be great to see how we can work together to get those reduced. For Dr. Hassani, there were some questions about the declines in the prevalence of hepatitis C antibody on the various surveys, thinking that antibody prevalence should remain more constant, as opposed to you could have a decline in the prevalence of virologic positivity. Do you have any thoughts about that, please? And you're on mute, Mohammed.
Thank you very much, John. Thank you for this important question. In the first demographics health survey carried in 2008 in Egypt, the survey was done for people from 15 to 59. Those who have the highest prevalence of HCV infection in Egypt are the older population. So when we did the next demographic health survey in 2015, those who are above 59 came out of the survey. So there is a reduction of HCV antibody prevalence due to dilution of the sample with those who are exit from the second demographic health survey compared to the sample in the first demographic health survey. Thank you.
Thank you. And one quick other follow-up, it relates to Rwanda as well, but particularly for Egypt, oftentimes the first 20% of a population need to be screened and found positive is easier to find than that last 20%. And you're really in that last stages of your hepatitis elimination program. Just curious, where do you think are the hardest to reach populations now? Are they in the cities or rural areas, or certain populations who are born outside of Egypt and maybe do not have a national identification card? What do you think are the remaining challenges to find that last percentages of people living with Hep C who haven't been diagnosed yet?
Now we are in a period of time that we try to recover the patients who have missed visits through the campaign, like those who are need to test it for SVR, those who are treatment failure. Amazingly, for us, the border governorates and this who are in the remote areas for the screening, we did a great job to reach them through mobile clinics and mobile teams that enhance our outreach programs, and those who are tested positive are treated in the nearby healthcare facility. We try to deploy more viral hepatitis treatment center even in the border governorates to enhance our outreach. We improve our learning curve from the past period of the national treatment program and the past screening campaigns. And even those some difficult to treat persons, like people who inject drugs and the incarcerated persons, we do a great job to reach to these certain groups to do the screening and to promote the treatment and follow up of them. And as I said in my presentation, and now we have viral hepatitis treatment clinics inside the addiction hospitals. This was not happening in Egypt before. And we have a legalization for the opioid substitution therapy and the strong needle syringe program that promote our way to achieve the elimination of hepatitis C by the definitions of the WHO.
Thank you so much. Then Rwanda, another remarkable program. Thank you, John Bier and Makusa Jean, for showing this. One question was regarding, were there other options for testing in Rwanda? Somebody wanted to know about home test options for Rwanda. Would that really be helpful, or dried blood spots? So I guess the general question, over and above the strategies you presented, are there other strategies for testing that you think would be helpful for Rwanda, please? And you're on mute. Oh, thank you.
Thanks, Susan. For the question, initially we used a mass screening strategy, and we are screening. We started by high-risk groups, and then we moved to the general population. It was a mass screening campaign. Then we trained our healthcare workers, including doctors, nurses, lab techs, and then we scaled up screening services to health facilities. Now, all the districts have been assigned a national joint hepatitis C elimination Umuhigo. I mean, it's a performance-based target for all districts. And then the mayors of different districts follow up with health facilities under his or her district. And then the population is sensitized and mobilized, and they go to the nearest health facility for the routine testing for hepatitis C and B as well. That's the current strategy that we are using. So we phased out the campaigns because they were not sustainable, but now our health facilities are responsible for the screening of the population at 15 years and above.
Thank you.
You are welcome.
Thank you.
Yeah, I can complement my colleagues for viral testing. Yeah, we have been suggested to use other testing in addition to viral load, which is being conducted in the OR site. We have about 15 sites, and this was used for HIV and COVID-19. We have been suggested to use GeneXpert and other tests, but we saw that the cost effectiveness is for using using HCV viral load, as it is integrated in HIV testing, and also we use some transportation vehicles which are being used for HIV, and this is being done frequently, and there is no problem for that. And using that, it's an effective strategy which is helping us, and also using people at health facility with registration of contact of people, and then asking people to come to take the result. It's somehow effective, meaning that there is no problem with testing strategy, but we need to improve also, to continue to improve every time. Thank you.
Thank you very much. Yeah, really excellent example of strategies to sustain a program over time, because these programs do have to last from year to year after that initial establishment, showing you how you're integrating it into your health system. So thank you very much. I want to thank all the speakers for providing excellent examples of strategies to implement hepatitis C testing on a large scale, as well as some of the barriers that still remain that need to be addressed for us to be even more successful in that regard. So I want to also thank all the participants. All of this information, the video presentations of the webinar, as well as the slide sets, will be available on the Coalition website. That's globalhep.org. Please let us know what you thought about the program, any other subject matter topics that you would like us to cover. And we look forward to continuing to work with you in the coalition toward our mutual goal of eliminating hepatitis. Thank you very much. Have a good day.